I spoke about minimal residual disease in adult acute lymphoblastic leukemia. Essentially, minimal residual disease, MRD, is what remains of the disease after the patient has been brought into complete hematologic remission, which is the essential condition to be cured. We try to cure these patients. So minimal residual disease that can be assessed by means of flow cytometric methods or more typically by molecular biology, PCR reaction, is the remnant of the original leukemic burden. And with current methodology, we can detect one leukemic cell in individual patients out of 10,000, 100,000 normal marrow cells. And this can be followed after repetitive chemotherapy courses in remission patients. And the information that we gather by looking for and finding MRD is that some patients harbor MRD in their remissions marrows, whereas other patients do not. It makes a big difference, because if we can't find MRD, it means that the patient responds well to the chemotherapy program being administered, and his prognosis is much better than patients in whom we can detect, we can trace MRD. It's kind of chemosensitivity test in other words. So we can reclassify the patients once in remission according to the MRD results, regardless of the initial risk category, which is defined by clinical criteria, say the genetics of the disease, the white cell counts, the phenotype, and so on. We can use different combinations. But nevertheless, once we detect minimal residual disease after a consistent amount of consolidation chemotherapy, that patient is always a high-risk patient. So we can reclassify the patients, both the standard risk of the high risk, into MRD positive on MRD negative. Makes a lot of difference. From the information, from the historical information, we know that the MRD positive patients have a long-term survival probability of about 25% only, say adult ALL, Philadelphia negative. Whereas for the MRD negative, regardless of treatment, we can skip safely transplantation. The probability of survival is in the range of 70 to 80%. So it helps deciding the final treatment. We go to that. The MRD positive is always selected for transplantation from sibling donors or family unrelated donors, because it's well known that performing a transplant in this category of patients improves outcome comparing to no transplant, from 10% to an average of 50%. It's still problematic because the MRD positive patients is difficult to transplant. Many relapse due to MRD positivity before transplant, and some relapse after the transplant. So the new concept is that we have to look for novel treatments, novel strategies to improve the MRD status, to prolong the disease-free interval in order to be able to achieve the transplant procedure and to improve the post-transplantation outcome. And this is the field of the novel immunotherapies, CAR T cells, the monoclonal antibodies. We can use other targeting agents, but it's a new world of treatments under construction.